In the UK, most operations are planned weeks in advance.
We're okay to go?
Okay, let's have blade, please.
But each year, 8,000 patients are so seriously injured.
You want to get gowned up, go, go, go.
Ready, steady, slide.
They need an urgent operation to save their life.
You are making very challenging decisions really, really fast.
This is like her leg tried to amputate itself.
At Addenbrookes Major Trauma Centre in Cambridge,
Addenbrookes resource special message.
100 trauma specialists and expert surgeons must bring their skills together at a moment's notice.
You got my mangled limb for me? It's a bit of a mess. It's going to need quite a lot of very complicated surgery.
All right, so you just bear with us. You're doing really well.
All under the most intense pressure imaginable.
There's quite a lot of force involved. God, man. We're not robots. We're human beings, but you never know when unexpected things can happen.
There's no margin for error.
His lungs aren't doing well, are they, Svet?
No, his lungs are not doing well.
Decisions that are made there and then may affect whether someone lives or dies.
This is nearly as bad as it gets.
From resus
Is she stable enough to carry on?
to theatre,
Go, 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 go.
20 specialisms combine to save one life.
Hello, Addenbrookes Hospital, resource.
Do the transfer from Ipswich A&E to Estelle.
A patient is in a critical condition after a head-on car crash.
Heart rate of 78.
78.
Respiratory rate of 18.
She's been assessed at another hospital, but her injuries are so severe, she's being rushed to Addenbrookes, where the trauma team can give her the specialist treatment she needs.
As soon as we receive a pre-alert for a trauma, the key is preparation. Trauma patients can be complex. They require input from multiple specialities. This is a transfer from Ipswich Hospital. It can be stressful, but you know what to do. They're coming into Resus 1. If you guys can be here, that'd be appreciated.
The patient is 55-year-old Carolyn.
She had injury sustained. She has an open left ankle fracture.
Okay.
There's a right-sided pelvic fracture.
Okay.
Multiple fractured ribs.
Sure.
And I believe they said a grade 1 possible cerebral bleed.
Initial scans have shown the cerebral or brain bleed doesn't need urgent attention. But the injuries to Carolyn's pelvis and the open fracture on her heel need to be assessed and prioritised by Muaz.
Carolyn.
Hello.
Good morning. So my name is Muaz. How are you feeling?
Yeah, I'm feeling tired.
Okay.
And quite a bit of pain with my leg.
When someone's transferred to us, we always do a top-to-toe assessment just to make sure there's nothing that's been missed out. I'm just gonna have a feel here. Is that painful?
Yeah.
Working fast, some injuries, the longer you take, the more unwell the patient can become. Can you try moving this leg for me? Is that painful?
Painful in my side and my back.
In your side, okay. Fine. Cardiovascularly, she's doing okay with a normal heart rate and stable blood pressure. She's got a pelvic binder on, but she's also got a known acetabular fracture. We've asked orthopedics to come along.
Muaz has determined that while Carolyn's pelvic injuries are severe, it's her foot and ankle that need immediate attention, from orthopedic registrar Sharif Ilarian.
Just take this off here.
This is gonna be painful, just.
Sharif's assessment shows not only is Carolyn's heel or calcaneus bone fractured, but her leg's tibia bone is dislocated from the ankle.
We cannot leave such an injury as it is. It needs to be put back in place as soon as possible.
If Sharif doesn't manipulate the bone back in place quickly, the tissue, nerves and blood vessels could sustain permanent damage and affect her ability to walk.
So Caroline, we're gonna try to give you some painkillers and a little bit of sedation. This only can give you this because the bleedings that you have gotten in your head might be a little bit painful, but it shouldn't take more than 30 seconds, 1 minute maximum, yeah?
Even though it will be painful, Carolyn can't be given too much sedation because it could make the bleed on her brain worse.
Okay, get yourself closer to this side. Bend the knee for you. Maintain traction, maintain traction, maintain traction, maintain traction, maintain traction. Just maintain it in this position.
Now I want you to take deep breaths on this.
The pain relief Carolyn can have is through an inhaler.
That's good. Keep going.
That's it. Hold it like this. Thank you. We're done, dear. We're done. Good job, Caroline.
Thank you.
Thank you.
You think it was successful?
Yeah. Yeah, it is as successful as a preliminary thing. The nature of the injury itself is not that good, unfortunately, yeah?
Right.
Just have further scans and we'll plan accordingly. I'll come back to you, yeah?
Okay.
Thank you. See you later.
Now the team need to scan Carolyn to determine which injury needs treatment next.
Just keep nice and still, Carolyn.
Breathe in, hold your breath.
The CT scan shows Carolyn has life-changing injuries. 3 major fractures in her pelvis and a heel that's so badly crushed, it could lead to her losing a limb.
This is the ankle. All the bones are fragmented, so they're not in a line. They're kind of shattered, so it might be a difficult procedure to realign those.
Carolyn's pelvis needs major surgery, but the open heel fracture takes priority.
Heel fracture is, in Carolyn's case, a significant injury because it's open, and there is always a risk of infection with an open fracture because the bone has been exposed to the environment outside the body.
The operation will be led by consultant trauma and orthopedic surgeon Lee van Rensburg.
An open calcaneal fracture is just something that makes me nervous. It's scary, because if that gets infected, the consequences of that are horrendous, including the potential for losing the leg.
No, I wouldn't worry about because I'm going down to have an operation, so. In a minute, yeah, so I wouldn't worry.
So multiply injured patients is the physical injuries, but there's this big psychological injury. You don't see it initially. Most people go into a sort of survival mode, just glad that they survived it.
No, honestly, don't worry. Yeah. Yeah, I'm okay.
But it comes later, this grieving of a loss of a life that they could have had or would have had if they hadn't had that accident. You've really crushed that subtalar joint, hasn't she?
Performing the surgery with Lee is orthopedic registrar Matthew Sear.
There's a large fragment. Parts of the subtalar joint are dislocated, so we've got to put it back where it belongs.
Carolyn's calcaneus, or heel bone, has shattered into several pieces. First, to prevent infection, Lee must thoroughly wash out the wound with 9 litres of saline solution and remove any dead fragments of bone that cannot be used to reconstruct the heel. Then, 2 wires need to be drilled into place, holding the fractured heel together while the bone regrows in place. Surgeons Lee and Matt are joined by a team of 10 for Carolyn's 90-minute surgery, including an anaesthetist, 2 scrub nurses, and to care for the patient before, during and after surgery, a theatre support worker.
So she's for wash out of her heel, so she's flat on her back. Once we wash it out, the K-wires and the DHS K-wires in.
When I walk into theatres, I just look around the room and just think it's so beautiful. There's so many people from so many different places around the world, all coming together just for that one person on the table. It's beautiful.
Hi there, how are you feeling? Okay. Now you might start feeling a bit more woozy. Think of a nice place you'd like to dream about. We'll see you in about 90 minutes.
For the patient lying there on the table, I can only imagine how, what that feels like. I don't often put myself in their heads because I don't want to be there. It's not a nice place to be.
Okay to go, Svet?
Yeah, you can start.
This has got my total focus. I'm in the red zone where the lights just come down like Who Wants to Be a Millionaire, and you're just there in the bright lights on your own with this puzzle in front of you which you want to put back together again. It's the most satisfying thing you can ever do. Oh man, I love operating. I would do it for free. Don't tell anyone.
Lee starts by removing small dead heel bone fragments that cannot be used in the repair.
This would have just been split inside a shoe, wouldn't it?
A plastic bag is attached to Carolyn's leg to collect the 9 litres of antibacterial saline wash used to clean the wound.
There is a degree of urgency to get this cleaned, washed out. Because if a heel bone gets infected, there is a chance that she will end up with an amputation.
There's the wash finished.
Walk down the bed as far as you can and just try and get an AP foot as best you can, man.
Lee will use x-rays during the operation to monitor how the fracture comes together.
You may drop a little more. Yeah, lovely.
Though Carolyn's heel is shattered, there are several large pieces of bone Lee might be able to use in the repair.
Put that piece in a pot for me.
Using the fragments to reconstruct Carolyn's heel could improve her recovery, but there's a risk.
Do you have the fragments for me? Our options are put the bone back, risk it getting infected.
There's a continual fight in my head. I want to keep this piece of the puzzle. I want to rebuild the puzzle. I want to make it look absolutely normal. But the consequences of infection are so big. The orthopedic surgeon in me knows.
Although they're nice big pieces.
This piece of bone can't stay.
I think we don't. If it gets infected, it's the one time that I have seen an amputation. So I don't think we're going for a reconstruction.
I remember that patient who had an open heel bone fracture who then ultimately ended up with amputation. And their life has changed. They're no longer walking the same path that they had before that accident. And you share some of their suffering.
Lee can't put Carolyn's heel back together piece by piece, so her walking will be affected. But what he can do is fix the remaining bones in place using thin steel rods called K-wires, so the bones can regrow.
Bones are beautiful things. It's one of the few tissues where it'll heal with bone. By getting the bone ends together, putting a plate or screws across it and holding it absolutely still, which allows different cells to sort of remodel the fracture.
All nice and clean, all the loose bone fragments are out.
With the wound thoroughly washed, Lee can now drill the K-wires into Carolyn's heel.
And so all we need now is to get a bit of stability to this hind foot, so I think we should just put a couple of wires into it. What do you think?
the wires.
Yeah, you sure? That looks like a heel, doesn't it?
Looks like a heel.
Oh man, I'm glad I'm not a foot and ankle surgeon. Move down the bed just a little. Push in just a little so it's less magnified. I'll get lucky some days, don't I? Okay, another K-wire, thanks.
K-wires are Kirshner wires, just surgical grade steel, thin little wires. The wires are there to give shape to the heel so that while it heals in a good position. It heals out to length and it doesn't heal out too wide.
So if we drive one along the length, we've got her stable.
Yeah.
Once the bone is healed, the K-wires will be removed.
By correcting the shape of the heel bone, by bringing back the length to the heel bone, it'll make it easier for her and reduce pressure on the tendons around the heel, and it'll make her walking more comfortable.
Perfect. This foot's now quite stable. I think we're done, aren't we?
Even though the operation has been successful, it's still another assault on Carolyn's body. So she'll need to wait 2 days before having the major procedure on her pelvis.
She still has other injuries to deal with. She still has the acetabular fracture, the fracture around the hip, and that's a fairly big operation that her body will have to deal with. We'll let the dust settle before we take on the acetabular fracture.
Okay, we have for today is just damage control to make everything safe. We had to do the heel bone because it was open. That's enough, just some dressing gauze, thanks.
Caroline.
Do you want me to
nice
take
big
her down?
breaths.
No,
Addenbrookes is one of the UK's biggest trauma centres.
Hello, sir.
Tell me if it hurts.
Their A&E deals with over 130,000 patients a year. And each week, 210 emergency operations take place. Some of the most challenging involve trauma to the foot. A complicated structure that can be difficult to repair.
Hello, Addenbrookes Research, pass your message.
Hello, I've got a 75-year-old female.
Yep.
With a left foot degloving following an RTC where she was clipped by a van.
Okay.
The trauma team are notified of an incoming patient with a crushed foot, where the skin has been torn off.
Don't know if you've actually just seen my message on Epic about the pre-alert that we've got coming in.
Because bones and skin are injured, a call is put out for orthopaedics and plastics.
If you just tell him to come to ED Resus then.
The emergency physician in charge is Joe Krakalici.
Degloved foot, don't know much more than that, to be honest. So the key thing that I'll probably need to know from you and ortho is whether we're going to need vascular runoffs of the lower leg or not. It depends how their foot looks, I guess. Emergency medicine definitely gives you a sense of how fragile life can be. Seemingly random events can significantly alter the course of your life just as you're going about a normal day.
It's almost 10 o'clock at night when patient Joan arrives.
Do you want to swing in and go head first, please, and onto that side, if that's okay?
While crossing the road, a van has run over her foot, sending her crashing to the floor.
Okay. So if we can have everyone listening up for a handover, if that's okay.
She's still got sensation in the bottom of her foot and the other 4 toes, but it's just the big toe. I do have some photographs for you.
She's got the head injury as well. Was there a bullseye on the van?
No, it was just knocked to the pavement when she's gone down.
Fine.
No loss of consciousness, no vomiting, no nausea, nothing like that.
So when I know there's a patient coming in who's been involved in a road traffic accident, the suspicion for them having serious injuries is quite high. Just keep your head nice and still for us, Joan. And what we're going to do is slide you across onto this flat board, OK?
Victims from RTCs, road traffic collisions, are not unusual for the team. Across the UK, they cause 150,000 casualties every year.
Orthopaedics and plastics. Shall we carefully take this off? I guess the question in my head, so we've got injuries at the top and at the bottom, so I'm going to do a trauma CT, and what I want to know is whether I need to do vascular runoffs as well.
Vascular runoffs are scans to check how blood is flowing in the injured area.
My initial concerns when I see Joan's injury are significant force has been subjected on her body.
And when touching here,
Yes.
you can feel it?
Yes.
Okay.
Joan has suffered a major trauma with multiple injuries to her head, hip, leg and foot, where a large area of skin is missing and her big toe is partially amputated.
There's a real risk that we get distracted by the dramatic looking injury and miss something more subtle but potentially more serious.
Pelvis feels stable,
Yeah.
no GP tenderness.
Yeah. So from a primary survey point of view, I don't think there's any immediate concerns. Just going to call CT. Happy you don't want vascular runoffs? Yeah. Cool.
The team don't need vascular runoffs. They can see while Joan's foot is badly injured, it's still getting a good blood supply.
Calling to request a trauma CT. She's hemodynamically stable at the moment, but given that there's multiple injuries at different levels, I think it's probably sensible to scan all of her.
Joe and his team need to determine what injuries require their urgent attention, so Joan is sent for a CT scan and X-ray.
Everyone ready?
Yeah.
Ready, set, slide. As we get older, we tend to sustain more serious injuries more easily, and patients can sustain life-threatening injuries even falling from standing height. She's got a degloved, partially amputated distal foot on the left, some pain over her left shoulder, head injury on the right forehead, and some right hip pain.
The images show the injuries to Joan's head, hip and leg are minor. It's her foot that needs immediate treatment.
I think the problem is all actually in the toe itself rather than within the metatarsal.
Joan will need an operation to assess if her partially severed toe can be saved, and if her entire foot is at risk, because she's lost so much skin.
An injury like this absolutely could be life-changing, and what we want to do is preserve as much of the function of her foot as we can.
The foot is made up of 26 bones, 33 joints, and more than 100 muscles, nerves, tendons and ligaments. All these must work together to make standing and walking possible.
This is an injury that could have significant impact on her function going forward.
Because Joan's injury is complex, her surgical team will involve 2 experienced specialists.
Pretty catastrophic injury.
Consultant orthopaedic surgeon Professor Stephen McDonnell and consultant plastic surgeon Kai-Yuan Wong.
Really difficult to say here with regards to if that is any chance of salvaging anything. Her toe looks bad, and I think we could identify that from her x-rays. So is there any way that we can salvage this toe?
If they can't, it will have to be amputated. But there's much more at risk.
Quite a significant injury, but we obviously can't see the soft tissue injuries here, so we just need to check the sole of the foot.
Yeah, I mean, that would change everything.
The sole of the foot has very specialized glabrous skin, which is very thick, has very specialized sensation, and depending on how much that is affected as well, that could very much affect the outcome.
If that sole of her foot isn't viable, then I think there's not a lot of options.
Without the irreplaceable skin on the bottom of Joan's foot, she wouldn't be able to stand on it.
If the skin on the sole of her foot can't be saved, then that could lead to a below-knee amputation.
Joan will need her operation tomorrow.
Tomorrow? Well, it would depend what time they do the operation.
Yes, thank you. Bye.
I have to go for a walk now.
I'll find his way out. Bye-bye.
For now, she'll spend the night on the ward.
My toe's beginning to hurt a bit
Your
more.
toe?
Yeah, a bit more.
Get some pain relief.
Yeah, thank you. We walked to the edge of the pavement and I looked to see that it was clear and started to walk across, then suddenly became aware something was coming and probably quite fast, so I tried to run the rest of the way across the road and it hit me. My husband must have picked me up and carried me to the pavement when I started to feel really faint. And I think I said to him, "Oh, you'll have to lie me down."
Joan's operation today is a detailed investigation to determine if her toe and the skin on the sole of her foot can be saved to avoid an amputation.
The plan right now is get you to theatre,
Yeah.
okay, clean the wound and assess what the tissues look like.
Thank you.
Okay? Perfect. Thank you very much.
Thank you.
Thank you.
This injury could potentially be life-changing, and depending on what we can do for her, it may well affect long-term kind of mobility going forward.
If Joan's foot is saved, she'll need a second operation in a few days, a skin graft to replace the skin that's missing. In Theatre 20, orthopaedic surgeon Stephen is assembling a team of 11 to save Joan's foot, including an anaesthetist, a scrub nurse, an operating department practitioner, and assisting Stephen, orthopaedic registrar Josh Ong.
Alan, are you still with us?
I'm behind you.
And the plan is for washout, see how much is left and what's salvageable.
We're here.
You focus on taking some nice deep breath. Think of somewhere else you'd rather be instead of here, maybe at home reading the paper.
So when we're unwrapping the foot, it's often entering into the unknown.
First, they need to decide if the detached toe can be saved.
Key for me, what is the colour of that big toe? Is it nice and pink and healthy, or is it dark blue and dusky? You know, showing that there is no real blood supply and all of the structures have been damaged.
It's already dark.
Yeah, it's already dark.
If Joan loses the toe, it will affect her ability to walk.
The big toe may take up to about 40% of the weight. By losing that toe, it's almost like learning how to walk again, in the sense of the weight will need to be redistributed more to the outside and central bits of the foot. So that will take some adapting to do as well.
I think that toe is already split. Any amputation is a difficult decision. It's not something anyone likes doing. Wow. But I knew that that wasn't a salvageable toe.
Joan's toe will be amputated. But first they must decide if there is enough good skin on the sole. If there isn't, she could still lose her whole foot.
So the key is to keep as much skin as possible. When we're looking at the tissue, particularly the skin on the bottom of the foot, the key is whether that tissue is going to survive or whether actually it may have started to die off.
If the sole, like the big toe, has lost its blood supply, the only solution will be to amputate Joan's foot.
And the sole is good, actually. Things are looking better than expected, and that skin is most likely going to be salvageable and not need to be taken.
How does that make you feel as a surgeon?
Relieved.
I'll just send suction on, please.
To ensure Joan's foot remains infection-free, saline wash is used to clean every part of the wound.
Sometimes we take patients back 2 or 3 days later and some more contamination is found, and then we would have to go through the whole washout procedures again before being happy that the foot is clean. Just come, let me bring this tendon up. because then we can attach that down. So there's a tendon.
Stephen must save what skin he can to cover the wound, to help the plastic surgery team repair the foot.
The question is if they want to fillet the toe to get the skin to come up, because actually you could probably get, that skin's probably helpful. Oh, hi, how you doing?
Good, how are you doing?
Good, thank you.
Plastic surgeon Kai has arrived in theatre after finishing another case. He wants to plan ahead for his own operation and assess the viability of the skin on Joan's foot.
So, my question was, did you want to keep some of this skin to try and bring back across?
Yeah, probably, actually.
Kai needs to remove any dead tissue and preserve living skin to use for the graft.
Probably what we'll do is we will take off what's obviously not, so that bit there.
Yeah.
Keep the rest. And scar. That's not. That would definitely. Oh, that would easily cover that.
Yeah.
Now they've decided what skin can be saved. The toe can be amputated.
Proline again.
Can we put some tucking sutures on that? I was going to say, just
we
a couple.
could do. Maybe just one there.
Yeah.
And then the rest we'll just leave it to see what happens. Let it declare itself. Do we have the vac dressing as well then?
Yeah, they're here.
Finally, to keep Joan's foot infection-free, a vacuum dressing is used to seal it and remove air and fluid from the wound.
Lovely. Perfect. Closes down quite nicely. Yeah. Perfect. Actually, that is a much better position than she was in
You have the back slap
a few hours ago.
It's going to be difficult to get her balance and walking back as she had before her injury, but hopefully the impact on her is as minimal as possible.
The toe is definitely not viable.
I agree. She's quite lucky.
It could have been significantly worse. I mean, those sort of foot run over can end up with an amputation. So.
Definitely.
Joan now faces an anxious wait to see if her wounds heal well enough to allow a skin graft in a few days.
Well, you're just waking up, dear. Any more painkillers we can give you, okay?
For the last 48 hours, Carolyn has been recovering from a head-on collision and surgery to her heel.
So this is the consent form for the operation. So it is your right, this area of your pelvis called the acetabulum that we are going to fix, yeah?
Now her body must undergo another assault, a second, bigger operation, this time on her pelvis, to ensure she will stand and walk again.
Can you feel me touching here? And here?
Before the surgery, orthopedic registrar Sharif must warn Carolyn of the risks.
There's a risk of affection of the nerves and vessels. There's a risk of stiffness and pain. And if any of these happen, we might need further operations.
I feel in a lot of pain and like it's a long road ahead. It feels an impossible road at the moment. But hopefully it'll get easier as the weeks go on.
Okay, have a good day.
Yeah, thank you, Andrew.
Take care, see you later.
Thank you. I remember the accident very clearly, the car coming round the corner on the wrong side of the road. I remember thinking, this is really bad. Makes you realise what's important and what isn't. So I want to spend a lot more time with my family and have special times with them now.
Performing the surgery to repair multiple fractures in Carolyn's pelvis is senior clinical fellow Alex Lee and consultant orthopedic surgeon Jay Rowell.
This is a seriously high energy injury. It takes a lot to break the pelvis in this manner.
I love bones. I love putting bones back together again. Trying to reverse that clock, get people back to where they were beforehand.
You know, we're not dealing with one fracture line, we're dealing with multiple fracture lines, let alone all the damage that's evident inside of the joint. Essentially, her leg has been driven up back into her pelvis so that the ball part of the hip joint, it's been driven up into the socket and it's split the pelvis of that pelvis in half.
There's a lot to consider when you do this operation. This wants to fall away, it wants to fall internally.
Carolyn's 7-hour surgery is in 3 separate stages, each to repair 3 main fractures in her pelvis, one at the back, another toward the front, and a final fracture near the hip socket. First, a long screw will be drilled through Carolyn's side to pull together the fracture in her pelvic ring. Second, through an abdominal incision, Jane must avoid major blood vessels to reach the fracture at the front of the acetabulum and repair it with metal plates. Third and finally, through an incision in the side of Carolyn's hip, Jay will use plates again to fix the final major fracture.
There's an immediate danger during acetabular surgery of injury. It's got straight away the bladder, it's got blood vessels, it's got nerves. The art of this operation is navigating those danger zones to safely get where you want to be and expose the fracture line so you can see what you want to, where you want to put this jigsaw puzzle.
Alongside Surgeon Jay and Senior Clinical Fellow Alex, in Theatre 16 a team of 15 are preparing for Carolyn's second major operation, including orthopaedic registrar Sharif, scrub nurses, and a team of 3 anaesthetists headed by Waylin Chung.
My main concerns were the bilateral central pulmonary emboli in addition to the chest wall trauma.
Since the accident, Carolyn has developed blood clots on her lungs. These should heal themselves, but could make her unstable during the lengthy operation.
So she's could be at risk of a significant deterioration and of course blood loss.
Okay. Any last minute questions?
No, thank
A lot of
you.
things going on, isn't it? Hang tight, all right?
Yeah.
Okay.
Take some nice gentle breaths. It doesn't have to be 2D or too fast. We'll look after you and we'll see you later, okay?
Acetabular fractures can be life-changing. There is a degree of chronic pain, difficulty with walking, with mobility, even when you get it right.
Shot there.
First, they need to stabilize her entire pelvis
Shot there.
and fix the first major fracture.
Shot there.
So a transsacral screw is drilled across the back of the pelvis.
This is a lot of what our trauma surgery is goal to be, is sort of minimally invasive. The next bit is big and open and horrible.
In the second stage, Jay needs to reposition the hip socket which was moved in the accident and repair it from the front. He starts by making an incision in her abdomen.
Essentially, if the hip socket has been pushed into the pelvis, the easiest way technically is to push it back. You know, rather than pull it back, is to push it back. That's a stronger vector. But to do that means going inside her pelvis.
She's quite deep, her pelvis, isn't it? She is, yeah. It sort of disappears away from you. Yeah.
But to get to the fracture, Jay must maneuver around major blood vessels, known as the corona mortis, Latin for crown of death.
It's aptly named. If you cut this without thinking and you don't have control, it's big enough that people can bleed to death within quite a quick time frame.
This is the front of the pelvis here. We've actually got to go down there, right at the back. As we come across, we'll come across some pretty big blood vessels in a minute, which we have to be very gentle with and maneuver out of the way.
Damaging those vessels can actually cause torrential bleeding. The consequences of that can be really serious. I mean, even limb-threatening or life-threatening injuries can happen.
It's right on it.
Hello.
3 days after Joan's toe was amputated, plastic surgeon Kai has decided that her tissue is in good enough condition to proceed with a skin graft on the top of her foot.
You're happy with what we're planning to do today?
Yeah.
Perfect. So we're nearly ready for you in theatre, so they'll be sending shortly.
Thank you.
Perfect. Okay, I'll see you afterwards.
Had a lot of hours thinking that I will have mobility and balance problem. I probably haven't processed it properly yet.
Kai will perform the skin graft by taking a thin strip of skin from her thigh to replace what's missing on her foot.
When we talk about plastic surgery, the instant reaction often is oh, do you do cosmetic surgery? But actually, the majority of our work is reconstructive, restoring or improving form and/or function. Take out the suture, look at the wound to see the skin viability.
Even though plastic surgery is common in trauma cases, that doesn't guarantee success.
Skin grafts don't always work. There are various reasons for that. Sometimes if the wound is infected. So it's very important to save as much skin, particularly in this situation.
It's here that we just need to check what we're going to do with. Yeah, it maybe it's quite small, so they'll probably be okay.
Kai needs to cover the wound with as much skin from the foot as possible to minimize the size of the graft.
So that should just cover up the joint. Okay, let's take the skin graft.
A wafer-thin strip of skin is taken from Joan's thigh with an electric dermatome machine.
A skin graft is essentially taking a very thin shave of skin, only about 0.2 millimeters roughly, and the site that we take the skin graft from essentially heals as if she's had a graze.
The thinner the strip, the less blood it needs to stay alive, increasing the chance of it taking.
Ridge is side up, so it's going to go onto the graft.
The strip of skin is mounted onto a board with a ridged surface that pierces small holes to create a mesh. This allows the skin to stretch further and lets fluid escape from the wound.
And the blade, please. Tiny side up.
Tiny side up. That's
Okay.
non-tooth forceps, please.
At this very early stage, it does still look quite raw, but during the first week, a dressing is put on the foot to keep the skin graft in place. During that time, it gets stuck to the foot and starts developing its blood supply over a few weeks.
That blood supply will come from the tissue underneath the graft.
Perfect.
All right.
Okay, can we have the glue, please?
Glue is used as it's less invasive than sutures, minimizing punctures to the skin.
The worst thing that could happen is that it becomes infected. So it's very important that it's kept clean and then we keep a close eye on it.
A vacuum-assisted dressing holds the graft in place and reduces the risk of infection by drawing away any fluid.
Okay, suction, please.
There you go.
At 75, without her big toe, Joan will have to learn to walk again.
It's probably good to get mobilising with physiotherapy on crutches.
Definitely. As soon as we get mobilising, the better.
Joan, can you show me your tongue, please, Joan? Well done. Good.
Good job.
Joan will be monitored in hospital for 16 days, so her wounds can heal and she can start rehabilitation.
just working around the important vessels and nerves at the moment, sort of that critical corner.
In Theatre 16, consultant orthopaedic surgeon Jay and senior clinical fellow Alex are halfway through a 7.5-hour operation to fix multiple fractures in Carolyn's pelvis.
It's being tension as we go.
Yes, and then it will tip.
They've already stabilised one fracture with a transsacral screw. But now, as they work towards the second major fracture at the front of her hip socket, they must carefully navigate around important blood vessels to avoid a catastrophic bleed.
This one may well be the external iliac vein or something going to it.
About 1 pint of blood per minute passes through the external iliac vein.
I don't like blue. I don't like red. I like bone. Working our way around the pelvis.
The approach is even more perilous, as Carolyn's anatomy has been altered by the accident.
Just being a bit careful with our dissection at the moment. Position of a nerve and the vessels are not where you'd expect.
The impact of the accident moves Carolyn's anatomy, her structures, into where they shouldn't be. So we might find the vein or the main veins not where we expect them, or occasionally even trapped in the fracture. That's not a nice place to be.
Gentle, 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 like that. Yeah, super gentle. Super gentle. Now it's like the big reveal.
Finally, they can see the fractured bone.
It's kind of like, you know, we spent an hour trying to get there, and now we're there. This is the plate.
Now Jay can fit the first plate to stabilise the break.
It's quite a flexible plate, but that's the plate that goes in, and we just need to shape it a little bit because we're putting it on a curve.
We use the plate to exert a force so that it will push the fracture and get it back to the shape that I want.
All right, yeah, God, man. We're pushing it back, the fracture back, with the plate applied. There's quite a lot of force involved in fixing stuff, controlled force.
But the plate isn't holding the fracture together and needs reshaping.
I think we probably just need to get on a recontour the plate. Should we take those 2 screws out then?
Yeah, sure.
Sometimes the plate, as you put your screw in, the plate might slip down because the pelvis is this incredibly curved 3-dimensional structure. You know, it's not a simple cylinder or a sphere. It's this really crazy shaped set of bones designed for force transmission and giving birth.
Jay uses a mallet to bend the plate into the right shape.
Actually much better. Looks much better. And the plate's now nicely contoured to the shape of her bone.
Okay, sure.
It's bespoke. Dolce & Gabbana can do this.
With another plate added and the wound closed, the second fracture is repaired.
Waylon, so is she stable enough to
Yes,
carry on?
we were just saying yes, she's stable enough to carry on.
Okay, all right, we will carry on.
After almost 5 hours in theatre, they can now begin the third and final stage, turning Carolyn on her side so they can access the final fracture through the hip.
Waylon, we're starting here.
Oh, there's Waylon.
Through a 15-centimetre incision, they cut through skin, fat and muscle to reach the bone.
That's the fracture. Yeah, that's posterior column fracture, right? I'm going to try and distract out the hip joint. Okay, I'm going to just do it.
Jay must physically manipulate the bone to get the fracture back into alignment.
Have I made any difference?
Yep. Yes, definitely. Yeah, one more wash. Oh, it's getting better and better.
You're just saying that.
No, it's good.
The trauma has put force through Carolyn's body. It's moved bits away from where they belong. It takes a lot of force and effort and technique to put them back where they were meant to be. That requires a lot of leverage or a lot of push in a way that is controlled and doesn't split the bone or break it. It's kind of the fun bit of orthopedics, holding a leg in a really difficult position and then trying to screw something very gently back together again. That's orthopedics for you.
Okay, pull up, bend. Yep. Okay. So I'm just washing all those. Okay, and then just one more pull hard, bend. Yep. Okay, good. There's plenty of wash there.
Done?
Yeah, it's done. It's well clear. I mean,
well clear.
Now clamps finish the work of bringing the bone together.
That's that. And a bit of ER. I don't know where that... Oh, that's it. Oh, there we go. Sort of came. Oh, well, this is like winner, chicken dinner.
With the fractures together, 3 stainless steel plates are added to this side of the joint.
That's it. I like that. I like that more. We're done. We're done. Oh, that looks good.
Gap we saw, it's gone. It's
Yeah,
closed
it's gone.
out.
It's gone.
So that's well reduced.
One doesn't know until you've got the fullness of time what the outcome of this surgery might be. Hip socket or joint injuries, they're not necessarily decided in the first year, 2 years, 3 years, 5 years, 10 years. You don't know the outcome for a very long time.
Carolyn, you're just waking up. You've had your operation. It went really well. Right, Caroline, we're going to recovery now. Okay. That's lovely. Well done.
Left foot up. Right foot up.
It's been 2 months since Joan suffered a devastating injury to her foot that required the amputation of her big toe.
I can't let go for long.
Regular physiotherapy is helping her learn to stand and walk again.
That's as good as it gets. When I'm not looking at my foot, I don't know I haven't got a toe. When it's being rebandaged and I see that I have no toe, it's a little bit of a shock at the moment. I don't think I'll ever get used to the idea. You don't realise how big a big toe is until it's gone. Do take it all for granted that, that everything will work. You just assume. And in your imagination, I think, you imagine yourself walking perfectly well, balancing perfectly well. Then when you try and do it, it's not always quite so good. Close the door.
The accident wasn't just a shock to Joan, but to Alan, her husband of 36 years.
He thought I'd been killed. It's quite a daunting thought. And that I'd have hated Alan to have been on his own, to have lost me. Maybe we should be walking together more.
Can do.
I'd made a decision somewhere over the last 2 months to look forward. It's no point looking back. Can't change it.
With age comes frailty. In Joan's case, she's in her 70s. However, knowing Joan's positivity, I think she'll get back to doing all of her activities as soon as she possibly can. And I do think that age is just a number, and that patient's state of mind is probably a really important factor.
All right, let's go, Carol, let's go. I'll get you into a room.
Thank you.
All arms and legs inside the vehicle at all times, please.
3 months after a head-on road collision, Carolyn has an important appointment with Surgeon Jay.
How's that?
That's lovely, thank you.
That's all right, is it?
I'm hoping that I'll be weight-bearing today and standing. Well, at least on one leg.
Just rest this foot to the ground. Your brakes are on?
Yeah.
Yeah? Well, just lean your weight forward onto your hip.
Since her major pelvic and heel operations, Carolyn hasn't attempted to stand.
After 13 weeks of just being in the chair, it's a very big day.
Do you want to try and stand a little bit?
Yes, I do.
Go on then. With being injured like that, you spend so long getting used to not using your leg that then to suddenly go and start trying to use it, there's a bit of a mental battle, a bit of a confidence hurdle to overcome before she'll be able to do that. Just take your time.
Oh, that feels weird.
Feels weird,
Oh, gosh.
but not crazy painful, eh?
Oh, I don't know whether I can take my hands off.
There we are.
Oh. Oh, wow. Oh, I'm up.
Feels all right, doesn't it?
Yeah, it does.
All right,
Yeah.
sit down.
Thank you.
That's all right. It's having a confidence, isn't it?
Yeah, definitely. I'm really thrilled about that. So, yeah, onwards and upwards.
Stand and reach for the frame once you got your balance.
Carolyn will need several months of physiotherapy before she can walk unaided again.
That's it. Welcome back.
Yeah.
How do you feel?
It's hard work.
It is hard work.
I'm not really thinking too far ahead at the moment. I'm just thinking day to day, just trying to get through each day and try and progress each day as it comes, really. Feels a bit of a long road, but just take it daily.
So this is a start of a different journey for Caroline, a journey of recovery.
You'll be walking your dog in no time now.
Often the patient, they find other ways of coping and dealing and discover new and different things about their own attitudes to life and what they enjoy and what they really get out of things. So spending time with family can be a real silver lining.